Welcome to the Counterweight podcast. I am Doug Rogers, your host, and I'm excited to share these stories of vision, passion, and growth leadership in digital health. I am focused on speaking to and learning from founders, growth, and operational leaders across the healthcare space about their journeys and lessons learned. We believe that a majority of people join healthcare companies, technology companies, providers, healthcare systems because they believe in the mission of improving lives of those around them. We will discuss with our guests their why for digital health. We will learn about success and challenges and what they learned from these events for themselves and for their teams. We will also discuss what tips and tricks these leaders use to help keep them positioned for success, as well as how they balance the tension between mission and margin. Join us each week for a new episode with our guests. You can find us on Apple Podcasts, Spotify, YouTube, and LinkedIn under the name The Counterweight. Subscribe, like, follow, and give us feedback as we go along. Now on to our show. Welcome to the Counterweight. My name is Doug Rogers. I'm joined by my co-host, Russell Stover, and we are beyond pleased. It's hard to say that, but it really is a true statement that we're joined by Dr. Paulius Mui. So Paulius, thank you for joining. Take a moment, introduce to our audience both who you are, how you spend your time, which, oh my gosh, I still don't understand how you find the time to spend the time that you do. And then we've got a whole slate of just really, really fascinating questions to pick your brain on.
Well, I'm really excited to be here, and thanks for having me. I have seen a couple episodes of your podcast. I think you guys are cool cats talking about interesting topics. So this is a
Hey,
treat
that's
for
high
me.
praise. Cool cats. I'm going to
That's
take
right.
it.
That's right. So my background, I don't really know what's helpful to share other than that I'm a big supporter of primary care. I like primary care for lots of reasons. I like to experience it, obviously, in different ways too, right? As a patient, as a physician, I run my own practice, do this part time. I really care about making healthcare affordable and accessible, and so I run it in maybe of a less traditional way, kind of a pay what you can model. And I kicked it off in Texas as a virtual practice, and then when I moved to Boston recently, picked up patients here in Massachusetts. Now I am actually negotiating a lease to have an in-person office, which is going to be really cool.
Oh, wow.
I think
I
it'll be
think that
fun.
speaks to the demand.
That's true. There's always a ton of demand for primary care. I also think that, virtual care is great and it can do a lot, but handoffs to the physical space is just another area that is poorly understood how to do that well. And so I think kind of want to walk the talk on my end. And that's maybe, you know, one day a week spread out over the week of how much time I spend on patient care. And the rest of the time, I'm a founder of a company focused on automating healthcare operations. We do a lot of things. I think we're really interested in workforce development. One of our main products is around chart review automation and peer review automation, because that's what basically the industry is willing to pay for. What I would love to do is focus on upskilling and education and how can we make people who deliver care better, because there's so much variability and it's not the individual person's fault that they may be struggling. It's the system that cranks people through. So the North Star is making people better, and how we get there, I'm totally flexible on the details. But that's how I spend my time these days. And, I try to surround myself with people who are curious and optimistic. I think there's plenty reasons to be jaded about just the state of affairs, everything from tech to VC to payment models in primary care. But there are people who see things differently and they feel like they have a sense of agency to do something about it. So that's how I spend my time, to be honest, and hang out with you guys.
Yeah, which is a bonus for us. Could be a bonus for you. Yet to be seen. Um, so you mentioned, just to orient our audience, you have opened a practice in Boston. You were in Texas. You're now in Boston. Our audience may have seen you commented on this on Rick Renard's post on LinkedIn, but there was an article that came out several weeks ago talking about Boston essentially being ground zero for the access problem of primary care. Now, that may be a bit of an overstatement, but certainly people feel, no pun intended, feel it acutely. And specifically, it was talking about this lady who called MassG looking for a primary care physician, said it was going to be 2 years before she could get an appointment, just a little under 2 years. And then they sent her an email and said, hey,
you can use this chatbot instead. She interacted with the chatbot and then got connected to a virtual care appointment. Paulius, I'm really curious. You've opened a clinic and you're seeing patients. Is access a technology problem? Is it a resource problem? Or is it a big health system problem in how they think about it and not really creating the right opportunities for people to engage with primary care in the best way possible?
I like how you're just throwing in a simple question there. Yeah. I think it's so unfortunate that like this person had this experience of, a 2-year wait. Also sounds a bit of an outlier and a bit
Yeah,
sensationalist. When I walked around, like when I was looking for offices, I walked into some medical buildings and just like kind of curious, like what is the wait for primary care? It was around 6 months, which is still like unacceptably long. But yeah, it wasn't 2 years.
it wasn't 2 years.
I
Yeah.
know people around the area that can see someone the same week. So I think there's always more to the story and depends how hard you looked, actually, which is also a bummer because people don't know where to look or, do they even, should like, is it acceptable if they've put in the effort, right? Ideally, you'd think humanity advanced enough to try to make it easy for people to get care. But yeah, not there yet. There's also, I asked about like, what does access mean? I think there's different types of access. There's access on paper. Everyone is assigned a PCP. So, coverage does not equal access in that way.
Access.
Right. I also think like for someone who needs a refill and has an ongoing relationship, like appointment totally appropriate. For someone who has very concerning symptoms and no continuous source of care, then yes, like you definitely want to have an in-person setting where you get treatment. So I think access is very like there's a gradient to it. And so part of me always is like, well, which shade are you asking about? Because there's more stories to talk about. Yeah.
Yeah, it's interesting. So as you were kind of talking about this, it reminded me of something, and this is like a very simple experience that I've had, which is I don't really know how to decide if a doctor is good or not. Like I don't really. I'm personally not a doctor, so like the way that I do that, the way that I decide is I ask other doctors. But I kind of wonder like how do if you were to go not everybody knows other doctors, right? So if you were to go and if somebody was to come up off the street to you and ask you how can I decide if a doctor is good or not, how would you tell them to think about that? Because that's a big challenge.
Well, I do like this question, and I still think it's a hard question. And this is the stuff that I spend most of my time thinking about because who's a good doctor? Underneath that is like, what does good care look like? And that might mean different things to different people. And then it comes down to like, well, what do we value from care? And then, well, how do we capture what we value from that care? And that's just hard to do systematically. Um, in my point of view, a good doctor or clinician is someone who isn't gonna like give up or rest until like your medical mystery is solved. Like there's someone who is just insatiably, like resilient, and is gonna accompany you in that diagnostic journey. So how can we find signal in all the medical data out there about who truly cares? Like that, I think, is a strong marker. And that's not captured in billing, right? Like we don't refer someone to someone like because they just bill really well, right? Like that's not what matters. What's interesting in the physician world, the referrals end up being very social, right? Like this is who you golfed with, or I'm not really into golf, but like this is who you hung out with socially. And then you're more likely to see them in the neighborhood or the same setting. And it's almost like the polite thing to do is like send them business. And the bar for, I think, continuing to do that is really low. It's like, unless someone does something egregiously horrible, you're most likely going to send patients, uh, their way. And that's what I've observed how like local community networks get established. I do think that we can get a lot more sophisticated about better patient matching, right? Because right now, if let's say you come to a new practice and there are 3 clinicians who are available. There might be an MD who's fresh out of residency. There might be an NP who's done primary care for 25 years, and maybe a PA who's done something for 20 years. How do you know who you should be seeing first? And let's say you have heart failure and CKD. Right now, most people might gravitate towards someone who's a doctor because, like in medicine, there's like this historic inertia of more school is better. But I'd argue actually, like, let's look at their track record and figure out maybe the nurse who's seen thousands of cases of heart failure and CKD, exactly what you have is who you should be paired with. It really comes down to experience, so to speak. So that's a framework to think through. And then what signals do we take in? Like right now, we judge goodness based on a very low resolution data. We look at like medical documentation, which is someone else's recollection of what happened that's been truncated into whatever a lot of time that someone had to write this down. And that, we're from that are supposed to infer like what does good mean. And most clinical documentation integrity is just around billing basically and coding properly so that the business continues to do well. What we aren't doing at a scale yet is looking at educational gaps in the notes and actually understanding where can we identify people who might be struggling with the conditions that their patients might have. So that's like an educational workforce development lens. Another layer that we could look at is actually, uh, richer data from conversations. Scribes are becoming more ubiquitous. So we have a lot of audio data that we're not doing much with just yet. But if you look at Zoom or other platforms, they have all these note takers that can give you a sentiment analysis. Like how rude is someone? Are they using profanity? Are they interrupting, speaking over others, dominating the conversation? And you can get a sense, to get that type of feedback. And so I think it's only a matter of time before we start applying it, hopefully in a non-Big Brother way to like help people improve. And then you can get into like the next layer of like video-based data, whether it's from observing the encounter, with cameras or like taking video feed from video virtual visits. So I think there's lots of layers and we're just at the early innings of all of this.
Yeah.
Sorry, go ahead, Doug.
Well, I was just gonna say I love the example of ambient documentation, and there's an opportunity there for both reinforcement and education. And I just put the other hat on in the sales world, in the SaaS world. There are any number of tools now that have proliferated that record your call, coach your call, give you suggestions either while you're in flight or post flight, and then elevate up to your executive. In a traditional, I say traditional, in a high functioning sales organization, the sales leader has that, is reviewing it with their team, they're coaching on objection handling, et cetera, et cetera. Do you see a model like that where that could work in the practice of medicine to coach how you engage in questions maybe you should have asked, or why did you not pull a thread there per se with your patient?
I think there's a lot of interest. So we're observing this from our customers, so basically like one of the use cases is doing chart reviews.
Yeah.
And we look at documentation and then we give feedback to people. And there was initial concern that people might not want like getting feedback because you're basically up in their business around how they chart or document and everyone has their style. But what's been fascinating is that did not turn out to be true. We are, and it's really fun. I always take screenshots of someone who interacts with us or sends me an email of saying like, this is crazy. Once you finish training, you stop receiving feedback in a way that is supportive because it just takes so much effort, and people do it at best annually because it's part of a checkbox somewhere. But when you can have a continuous like coach or method of improving what you do, people really ask for, they're like, can I upload more charts? Can you look at these conditions? I know I struggle with them. And it's particularly true for young learners, like less experienced learners, those that might have done, less schooling than medical training. And, so Like there's a lot of nurse practitioner schools that are purely online, and they do a lot of their training on the job. Not PAs don't necessarily have the equivalent of a residency program. There's different types of training. And so these individuals really tend to benefit from those types of reinforcement mechanisms. The hard part is finding a business model that allows for this, because most organizations just don't know what to do with technology yet, and scribes have been the only way that, like, what people have invested in so far. And then obviously they're investing in revenue cycle tooling. This type of workforce development is just, there's not a crazy amount of appetite in the industry because it's so early. And so just to like add on to what I already shared, is because we see that people are not sure how to pay for this, things that we've created, we're actually going to be open sourcing just so that
Mm.
people can have access to the best tools and technologies without having to wait for the business model to catch up. And it almost feels like, when I don't know what that feeling is to invent a seatbelt or a vaccine, but it feels like we've found something that is going to impact safety in a significant way. And like, why sit on it and hold back? And, we can do that because we've not promised some crazy stick story to investors or anything like that. We're, self-funded company, and we just want to advance the field. And I think that if we get to push the field forward, we'll get pulled along the way, right? Because we can help others see around the edges where they might hit bottlenecks. We maybe can guide people. So whether this becomes a managed services software or it just becomes more of a services approach to making people safer and better, I'm fine with that. But that's how I see some of this industry evolving in like practical terms.
Who's going to be most open? I know you're doing this today, so I suspect you've got signals to this regard, but are health systems going to be open or resistant, or is it going to be your independent practices where the physician or physicians are both the owners and they have a more direct impact in terms of the patient relationship that they have, and then they feel very directly the impact of their care? Not to say that if you're an employed physician you don't feel that, it would not suggest it, but just there is a difference in my mind. I'm just curious, what signals in terms of who would lean into this first are you seeing?
Well, I think there's like multiple layers of how to think about it. One is, the principal agent issue, that the buyer isn't the user. So at the
Yeah.
health system, that is the big holdup, is that people who would benefit a lot from it are not often the ones buying it. It happened to worked out with scribes that there was like more of an emotional benefit to it. I think on the private practice side, the users are often the buyers. And also if you look at the increasing number of shadow AI tools, right? Like the ones that are basically unsanctioned, that are just like product led growth, that you don't tell so much and you kind of utilize it maybe on your phone. Like this has historically always happened. Like doctors would send each other photos of rashes and like, hey, what do you think? And right, like the health system legal people would be like, don't tell me about this. Like I don't want
I
to
don't
know.
want to.
So I think the adoption is hard to predict. I think, for health systems, you either are going to drive revenue or you're going to, decrease costs. Like those are really the big levers. And uh, I think that people will come around because, for example, it's very hard to understand what is an appropriate referral to an emergency room, like from an outpatient clinic to an emergency room. And it takes a certain business model where this is important, like, more of a capitated value based arrangements where people have skin in the game for downside risk to care about this. Because the flip side of this is if a health system benefits from having people in the ER, right? Like, why would they want to try to decrease, basically people that come in? So, I think your answer really depends on the business model, as with a lot of things in healthcare. Yeah.
Yeah, no, that
Yeah.
makes sense.
Yeah. Yeah, it's interesting. I'm using Gong for the first time, and I mean, it's monitoring what you're doing. And I'm using it as a salesperson. It's exactly what Doug mentioned. You can go back and look at, how did you place these questions in the right place? It's a quality control thing, and it just It doesn't, I mean, as a salesperson, you're bringing in more revenue. And if you get better at doing your job, then you bring in more revenue for the company. If you get better at your job in a fee for service health system, it's hard to say what that impact is exactly.
Yeah. So how does Gong work, for example? Is it like a note taker? It listens in your
Yeah,
conversation.
so it's a note taker, but it's a little bit more than that because they've mapped it to some traditional sales frameworks. And based on those frameworks, they're looking at the full content of what was discussed, and then basically taking a component of that discussion and plugging into a field that they've mapped it to. So, for instance, trying to think of something, but in a discovery call, you might be asking questions about what their processes are for signing contracts,
Mm.
and it will kind of take that information and specifically sort it. And then it integrates with Salesforce, which is a system of record. And Salesforce has a home for those particular fields, and it can automatically upload them into it. So it's pretty interesting.
Yeah. And I think, traditionally healthcare has just lagged behind other industries because it's so highly regulated. And so I think whatever we're observing in the sales, right, and fintech space, like we're gonna get there.
Yeah.
It takes time. Yeah, that's really interesting. And you found it helpful overall, like using that software?
I've just started using it. I do think it's going to be helpful. It kind of, I think I'm not a young salesperson, but I think
What?
that even as an old salesperson, it still takes some, there's still steps that everyone misses, and it kind of it guides you through what you've done incorrectly, but it also just makes it easier because it's taking something off your plate, and you don't have to, in a conversation, and this is kind of this might lead into another topic, but like, I mean, as a salesperson, what you really want to be is you want to be present with that client or that customer whenever you're having a conversation with them. And if note taking is, some people take notes because they need to, but if note taking is taken off of your plate, then you can be present, and that's important for an interaction with the customer. In the same way, well, not the same way, but in a similar way, the doctor-patient relationship where, you can be more present if you don't necessarily have to take notes. But I know that some physicians still want to. Everyone's a little bit different.
But I would point out the incentives are different, from how ambient documentation both gained traction and the sales motion, the value proposition, if you will, to the physician slash health system versus these automation tools on the sales side. On the health system, I know we're saying this that our community really understands, but the benefit to the physician, you don't have to turn around and type on the computer. Benefit to the health system, physicians happier, a little bit more productive, and oh, by the way, maybe the chart's a little bit more cleaner. On the sell side, or how these tools have proliferated in the other side of the industry, they're doing the same job. It's ambient documentation. They're capturing the conversation and they're inserting it in the source of the record. However, the incentive is different. It's less about putting it in the record and it's more about examining, did Russell do the three things we expect of him? And if he didn't, it's an opportunity for coaching. And now we've taken coaching off of the human leader side and moved it to the technology side with the human leader being a validation step.
Uh-huh.
Paulius, what I hear from you is you're talking about a future where there is a similar type of scenario for the healthcare provider where these tools can provide coaching. And I almost wonder, as long as we keep that as a carrot and not a stick, that's a really good thing, but there's always a little bit of a stick that can be applied to.
Yeah, well, often the regulation is the stick,
Yeah.
but I do think that if you think about it from the what's happening in the professional athletics, right? Like Michael Jordan had a coach, probably multiple coaches, to be honest, for like different parts of the game. And even people at the top of their career and their performance still have ways that they want to improve. And right, like chess players, I listened to this interview, this was like a while ago, but from chess.com, I think it was one of their product people were talking how they noticed that chess players like to study the games they won a lot more than the games they lost, which was counterintuitive. But like they still engaged with learning like what they did well. And I
Yeah.
often think that right now we're very much like paternalistic. Let's wait until a bad outcome or a complaint and be very reactive in how we handle a lot of things. And maybe that's just because this is so low on the priority list. Let's get the most patients in the door is like kind of like the top line driver for a lot of things we do. And I hope that with our emphasis on quality, and then maybe let's say quality gets really good across the board, then it's going to be hospitality as the differentiator, right? Like what we've seen with more of the higher end, high touch services. Then it's going to be a matter of having taste and having a distinguished like approach to care. And maybe that is going to be where the emphasis around coaching, I think, is going to be like really valuable. Because I worked in the hospitality industry for a while, from like in restaurants, front of the house, back of the house. I worked in transportation, in real estate, and like, all these things are about people and dealing with people. And I've continuously been fascinated by learning how do owners of hospitality and, businesses choose who they hire. And they really thought that, you know, it's one of those things like whether like your parents raised you like in a certain way or not. Like I don't know if it's like the street smarts or the savviness that people just get of how to deal with people, but like at some point you can read all the books and it just like you may not have what it takes to really like deliver really like a high quality experience in any industry. One question is, can we teach this? I don't know, but we're kind of, this is like solving for the 1% probably. I think we have so much more work to do, and like I really want to focus on elevating the floor, not raising the ceiling, which is unfortunately most of the conversations, especially on the social media platforms. It's all about, the one percenters. But I know there are people that are putting meaningful resources and effort into raising the floor. So that gives me hope.
Yeah. Well, hope's a good thing, and I certainly appreciate the distinction between raising the floor versus elevating the ceiling. And just from a macro perspective, we have no shortage of need, and yet we have plenty of shortage of people to do the work. And so elevating those that can do more and improving them seems to be a very logical perspective. I'd be curious, you've been practicing for several years now, some amount of time. You see patients. You also are very immersed in both education, technology, the dynamics of what's impacting care today. What are you seeing change on the patient side? Meaning, if you think back 5 years from now, or whenever you started practicing to today, when a patient walks in, what is different about how they approach you? And I asked that a little bit with this echo chamber behind us around all that, OpenAI just came out with ChatGPT for healthcare. There's been Google, right? Everybody talks about Google for health, and people Google their symptoms, et cetera. This has been a trend line that's accelerating. But I'm just kind of curious, as a practicing physician, what are you seeing different today from your patient experiences?
I think I've been in different settings, and the setting I think matters just as much as the arrow of time. I trained in rural Virginia, and um, I think all patients are, were very old school and grateful, and like the tech, like we had, phones and other things, it like they didn't care about any of that, even if they could get their trends and look at things. Like they just wanted to shake someone's hand and like learn where their doctor like grew up, and like that's what was important to them. So I think in certain communities it's going to take like generations to, I think, change some of these things. Now like fast forward to the other extreme where I have a lot of tech savvy patients, the comfort of being able to text about symptoms. And like there was a patient that I had, last week. She was just having this horrible upper respiratory infection, and we were like really not sure, like, should we escalate care, or whatnot? Because we tried to do it all without, having to do an in-person meeting and wanted to look at her throat. And she took like a very well lit picture of the back of her throat. And I was like really impressed. It was just like with just her home phone. And it actually gave me a lot of data points to like figure out
Huh.
what to do next. And so I'm kind of surprised by the level of patients that like, and their like health literacy, tech literacy, people read up. And some of the questions that I'm often asked around, it's not about like, what does this diagnosis mean? It's more about what does this diagnosis mean for me? Like, if I do this test and I get a diagnosis, is that gonna impact like my ability to get insurance in the future? Like, is that gonna make care more expensive for me? Or like, what would you worry about knowing me? Or what should I worry about? Like, these are the questions that are highly contextual. So even if you chatted with AI for years, I think there's still so much rich data that is offline that really is what patients care about. And contextualizing that, I think, will continue to be really, really relevant. And, I kind of joke about this, but it's like the primary care physician, the PCP, like I almost think the C is going to be a lot more about context than care. And so that's what we'll be able to translate, right? And there's these different worlds that patients experience. There's the insurance world, there's the virtual care with a Zoom world, then there's just text-based messaging, then there's like fancy marketing, new startup world, and like the crazy part is a lot of these things are short-lived. Some like the insurance can go out of network, they get in a fight with the hospital and they're gone, and like like no one's really invested to have a true relationship with the patient. And like to me, the relationship is about like context and and more of the tech speak, so to speak. So yeah.
It's interest. It's I appreciate you bringing up your time and in Virginia. Doug and I often talk about rural healthcare, and that is one of the. And I know that you've mentioned this before too, Paulius. But there's the amount of time that people have consistent care with a primary care provider has kind of gone down over time. But one of the places where people tend to actually have a relationship with their primary care physician is in rural America. I that's the one thing. There's this rural transformation fund that's been created. One of my concerns, and I'm very excited about the potential for technology to expand access, but I certainly do worry about you know places like rural health where it's like one of the core things that actually is better about rural healthcare is that relationship that exists between patients and their primary care physicians. And if that in particular gets broken, then it really does concern me about what could happen there. And I'm hopeful that these tools, people think about them enough to understand that, that relationship is something that can be expanded with them. But, it's something that I think about and I fear as we move on.
I just one quick aside on rural healthcare. So pause to Russell's point. We've been doing a whole section on both talking to builders and founders and providers who are experiencing rural healthcare, who are building for these rural communities, and obviously the impact of the Rural Health Transformation Fund. I would throw out. I don't. I would argue that healthcare in rural communities is a problem that is better solved by creating economic opportunity in rural communities than trying to create a technology innovation in a rural community. And don't get me wrong, look, I'm incredibly bullish. There's a lot of work I'm doing in my professional life around extending care, especially using AI agents, et cetera. But I think that if you think more so around the healthcare delivery arm as an economic engine, and creating a center of economic opportunity, both from a healthcare perspective and then creating other services in that rural community, then you're going to open up more opportunities to deliver care, to attract resources, et cetera, versus if you orient only to virtual or agentic and it completely disintermediates the person, then it's actually going to hollow out rural communities much more because you're going to take away some of the economic impact. Just an aside, I just,
Yeah, I think it's a good observation. I think it's like fire, right? You can cook a meal with it. You can burn down a house. Like
that's right.
it's like how you wield it, and technology. It's like the whole thing. Like People have never been more connected and isolated at the same time. And I think it just,
Yeah.
I think what it takes is, a different kind of leadership that really, I think, you know, walks the talk. And I think it's not going to be one leader that advances, I think, like every community's thinking. I think it's going to take like local leadership and the local values to be mixed into like what people care about. And ideally, there's some North Star, like as a culture, that we want people to, have the fundamentals, kind of just the basic, things. And I would love to think that primary care is one of the fundamental things that everyone should have access to.
Well, I think we would agree with that. Well, collectively on this pod, I think we would have, uh, we could certainly divert into a right versus a privilege.
Yeah.
Just for full awareness, I skew to it should be a right, not just a privilege. But right, that opens up a whole bunch of questions around then if that's your principle, then how do you live into that as a community, as a government, as a country? I'm curious, Paulius, how do you use AI today? How is it most impactful for you, either as a business
Um,
owner, as a provider, or just as a person?
uh, I mean, I think I get to try. I try to be in the driver's seat, but like just the way, almost like how I treat a lot of the technology. I have most like everything on silent. I don't let technology interrupt me or my thought as much as possible, unless like I'm expecting a call from a patient and like something's going on, and like then I'll put my phone on loud. But otherwise, I try to let me and my curiosity, my interest guide how I engage with the tools that are available, right? So like on the company side, I mean, we're doing some pretty cutting edge stuff. We're not developing the LLMs ourselves, but we're using the latest available tools to like figure out where the edges are and how can we, do cool stuff around workforce development. Like that's plenty fun. On the personal side, I feel like I honestly don't use things too much. It's almost like if something took me 10 minutes to Google, I might try to put it into a query that is going to like surface some ideas of like right now I'm planning a retreat, and so I'm using tools to help me think about like things to do or whatnot. And then as a patient, I feel like that or a patient or like in the clinical sense, I think it's a great educator tool, and it's like it level sets everyone, and you can tailor like how you communicate more complex topics to like personalized level of health literacy. I think that's a pretty cool way to leverage tools. Yeah, I mean, you can also create images and videos. I've played with that. That's just kind of fun, or music. Yeah, I mean, it's just like somewhat on the personal level. I think it's more of a toy. I don't try to like automate, like my life or relationships or anything like that. Yeah, there's some joy in being inefficient sometimes.
Yeah.
Feels like a luxury.
So this is kind of a really hard technical question, but I think it's an interesting one. So I think with your platform, Polys, you use synthetic patients, right?
We have used them in the past. I mean, right now we're working with real data, and for on the education side, we use mock data.
Okay. Um, well, I know that you experimented with them. So I
With the synthetic patients, let's be very
yeah
clear. You're not experimenting on real patients.
yeah
I
well
don't
right
think
right
that
Yes,
we're not
yes
breaking news here.
yes in a mock environment. Okay. But
yes,
so I don't know that I'm not sure that like our listening audience is familiar with the difference between like a mock patient and a synthetic patient.
yeah.
How would you describe that? And what are some of the possibilities that are there?
Yeah, the good question. So you were asking about mock and a synthetic difference, but those are more similar. You probably meant synthetic and real.
Yeah.
Is that right? Okay. So one problem that we were solving is so we identify people who have had not enough experience in something. Like when I finished residency, right? Like 3 years of intense family medicine training that included like working in ER, hospital, delivering babies, seeing newborns, moms and their grandmas. We cover a lot. But like I just didn't get a lot of practice for patients who had like menopause conditions or issues or whatnot. And so when I started working in the real world, the patients that I had to read up a lot. I had to ask my colleagues. I'm like, hey, what would you do in this case? And just learned on the job. There's still things come up that I'm not had enough experience with. So how can you replicate something that only is gained through experience? We simulate rare events in our training. So how do you do chest compressions for CPR, right? When someone basically dies and their heart stops. How do you bring them back? How do you do injection into the spinal cord, or you don't inject into the spinal cord? You sample like cerebrospinal fluid for infections, and these are procedures that don't happen regularly, but they happen. But you need to be prepared to do them. So we practice. What's crazy is when you think about chronic conditions, they're everywhere, like ubiquitous. Chronic disease is everywhere. But it's actually a rare event from a training perspective because our care is so fragmented. I've seen patients who have had diabetes, but there are all different flavors of diabetes. Some patients were already on insulin, and I just had to click refill, and I didn't really use a lot of brain cells. You know, Other patients were on like these four crazy medications, and I had to think about the interaction of them. But those 10 patients with diabetes that I might have seen were almost like 10 different diseases and conditions. And so when in the real world, when we're doing our chart reviews and identify learning gaps in individuals, how can we let them get better at the, competencies that they have not yet developed? The only way is for them to wait for the next patient to come in and basically get practice on. So what we've done is we've taken EMRs and treated that as like a pilot's cockpit, so to speak, because that's where this is how we fly around clinically, is we mostly stare at that screen. And so we generate patients that look real. By standing over someone's shoulder, you would not know if it's a real or a fake patient. And then we let other people basically finish taking care of them. So the story, like the patient's story and maybe medical history and exam, is already written out. And you get to decide, do you put in orders or order labs or referrals? And then we apply the same technology to basically evaluate how well they do. And that like checks a lot of boxes. It lets someone practice on things that they haven't seen enough of or things that they struggle with. And you can basically customize and tailor these basically patient simulations to the local context. So, like in this zip code, there are a lot of Portuguese speaking women who have gestational diabetes. Well, you can create that type of patient and you can let someone practice, we're not doing the speaking simulations, but there are tools already that can do that. And so that is one application. And then you basically, with technology, can have a substitute in for a preceptor and attending who's coaching you and guiding you along the way. So it's just hard to have a business model that makes this tick. I think this is a cool thing to do, but to make it sustainable where you're paying your bills without maybe like giving away agency to a venture capitalist. And it's not about giving like a chunk of the company. It's often giving a chunk of your vision to someone else.
Yeah.
Because they might just direct you in a way that you don't want to grow, and you don't really have a say, like, unfortunately, because VCs can replace the CEO and do other things and whatnot. So yeah.
Yeah, well, that you put in a nutshell both the good and the bad of being in a growth mode where you take outside capital, and it's not an easy decision to make without a doubt. Paulus, I know we're coming up on the end of our time, and I think we've covered some phenomenal ground. I will say, just as an observation, I am both more hopeful listening to you, but also at the same time more anxious. So that's a weird place to be. Thank you for that. I am more hopeful for the journey that providers will be on in terms of delivering the best quality of care because they're learning from the community around them. And you posted, we'll put this in the, I mean, you're prolific in terms of posting these insightful articles on LinkedIn that pulls forward the evidence, but one of the ones you posted recently was specifically talking about learning from your mistakes and how really good physicians are willing to talk publicly about it, and then what the
Mhm.
evidence shows, and then how that improves the care delivery. And then certainly as you talk about the work that you're doing within your startup and the technology platform, how you're creating an accelerated ability to do that at scale, not just on an anecdotal one-on-one coaching type of basis, which is really powerful. So I I'm probably more hopeful of where medicine is going to be able to go on a personal level because of the work that you and others like you are doing. I'm anxious because I want to see more people adopt it. Here's the final question I have for you. If you got elected, I know that's a big word. If you got elected president tomorrow, let's set aside the campaign you would run. Did you take donations? Like what, who are the people that you staffed it with? Did you do Oppo research? We don't need to know all of those details. But if you got elected president and you are going to go launch a new health policy for the United States, what would be the hallmark of your health policy?
Oh, man. Yeah, really fun question. I would give special treatment to primary care. And the way I would do that is like I would create a universal license to practice anywhere in the US
I
to
like it. Yeah.
allow for continuity. Because like when I was in residency, I was a young patient, kind of like my age, and was diagnosed, I diagnosed them with depression and started on medications and they got better and like that was really cool and I did their refills and nothing else really was going on, but I knew the ups and downs of their story. And then when I finished training, I basically had to say goodbye to them and didn't have a choice to continue the relationship. But we totally could have maintained the therapeutic bond that we created. And I moved away and they were asking like, could we do this? And there's even some patients found me on LinkedIn and reached out and like, just like wrote these really nice letters that, they don't think they will find someone like what we had. And I was like, yeah, I mean, you will. But like those things did not have to end. And I don't have to be the only doctor in their life. I could just be the person who has the collector of their context. And I can help, just navigate some of the issues that they might have with other doctors or otherwise. And I think just having someone like that who's constant, is really helpful. And so I think that would really change people's ability to just be more mobile, right? Like a lot more younger people travel a ton. And if like, I just almost think that if you can play into this card of look, like being primary care, like actually unlocks so much. And I'm just keeping it simple.
I love that. I would campaign for you if you decide to run on that platform. Yeah, I wouldn't say I'm a single issue voter, but maybe I am for this particular. Primary care is the best care, and let's make it universal for everyone who can, should, and would like to get access to it. Paulius, this has been a phenomenal conversation. We appreciate you making the time. We watch, listen, and read and learn from you nearly every day with the things that you're talking about, and I just say we respect it and we appreciate it. And we hope that our community gets value from this conversation. I know that Russell and I have. Thank you for joining us today.
Well, thanks, man. I think this has been such a good talk, and I wish I could actually hear more of your ideas and opinions. I know I was more in the spotlight here, but thanks for letting me share what I have to say. I'm always more of a learner, in my mindset. I think one thing that I would just add is like what you told me how like this is giving you hope and anxiety. I was recently on the New England Journal of Medicine podcast, not otherwise specified, and people have texted me a ton just saying like, "Oh my gosh, I heard you." And what was crazy is actually a number of doctors reached out and said, "Hey, that's actually the last thing I was looking for to do my own thing." And they've been in
Wow.
employed places and they're like, I was thinking about it, but like the conversation I had with Lisa, they're just like, look, actually, like that was the last straw that gave me confidence knowing that someone else is doing this. I'm going to do my thing too. And I think that is the coolest thing. So hopefully that is going to make you less anxious because
It does.
people are really like, taking ownership and like doing stuff.
Yes, indeed. Great way to end the conversation. Thank you for the time.
Thank you for listening to The Counterweight. We are excited to bring new episodes out, and we are incredibly grateful to our guests and our listeners. We are committed to telling stories of those building and engaging at the intersection of artificial intelligence and healthcare. Let us know what you think by commenting on the episodes. As always, you can find us on Apple Podcasts, Spotify, YouTube, LinkedIn. Subscribe, like, and follow, and we look forward to joining you again next week for another episode of The Counterweight.